Hello friends, and I'm so glad you joined me today. We are going to be giving the liver its due love today, and it has been far outdated. The liver just gets no love. It really drives me a little crazy because the liver is one of the most fascinating organs of the body. It does so many things and is so poorly understood and poorly appreciated. So today we're going to be talking about how to work up, what pertinence you need to pay attention to, the labs, making the diagnosis, and the laundry list of sequelae that can happen when a patient is very sick in the ICU with decompensated cirrhosis. If we haven't met yet, my name is Bree. I'm an RN, NP, mentor, interview strategist, content creator, and author. Welcome to the channel. Okay, so if you watch my stuff and you've been following me for a while, you know that I made a couple of videos early on in my YouTube journey talking about specific diseases, how to work them up and write notes on them. And I kind of veered away from that, and I wanted to get back to it in celebration of finally finishing my second book. And I say that with drama because it was a large amount of drama in my life. It took me forever because I wanted it to be perfect for you all. So it's finally done. So from this book, I'm going to use the sample patient included in there. So I'll present the patient to you. I'll give you the story, the labs. You make your diagnosis and work through what you think I would put in the note. And then we will talk through the note. And it starts with some behind the scenes on educating the pathophysiology of decompensated cirrhosis in and of itself. Then it's followed by the specific sample, like the note that I would write for this sample patient. So hopefully this will be very helpful to you, but bear with me. Just hang in there, friends. It's going to get deep. It's going to get complicated, but I'm going to break it down in a way that I think will be more manageable for you. So I realized I'm watching this video back and never actually told you the title of the book. So let's go to my website real quick. It's here. The Ultimate H&P Cheat Sheet is the title of the book. The original text was released maybe a year and a half or so ago. It is 11 of the most common ICU problems with assessment and plan templates. And I give you a sample patient, and then we walk through 11 common diagnoses that you will see, sort of some teaching behind the scenes, the pertinence you need to include in the assessment and plan, and then a sample so that you can load it into your hospital's EMR so you have a dot phrase already ready for you. And the follow-up is called the Ultimate H&P Cheat Sheet Companion, and it has 11 more problems. So today we're going to be focusing on the problem of decompensated cirrhosis. And in just a minute, we're going to go through this particular patient, this sample, and we're going to talk through how you work up, make a proper diagnosis, make a plan for this patient, and then a sample that you can upload into your hospital's EMR. So there's the book, and here's my website. It's breenp.com. Okay, so here is our patient. This is a 57-year-old male with this primary medical history, which has a lot of cardiac focus on it. He's had an MI, he's got heart failure, he's had cardiac stents, most recently placed 3 months ago to the LAD. He's been on antiplatelet therapy. He has vascular disease, as you can imagine. He's a smoker. He's a drinker. He comes in the ER with his wife, complaining of dark red bloody emesis times a couple of days with melena and confusion. Last known alcohol was about 2 days ago. In the ED, he was confused. He was hypotensive. He was tachypnic. He had AFib RVR on the monitor and 2 episodes of coffee ground emesis. And this is why you are called as the critical care provider to admit the patient. GI has already been called. They're planning for urgent EGD, and they're requesting that you intubate this patient prior to them doing so. So he also has associated diagnoses of decompensated cirrhosis with alcohol withdrawal, hyponatremia, AFib, and coagulopathy. He's already on a protonic strip. He's received 2 units of blood, vitamin K, and as I said, GI has already been called. He is requiring Levophed currently, and here are his labs. I'll let you kind of soak those in for a moment. This sample, so these labs are designed to reflect a multitude of problems that are included in the book. So you'll have to kind of tease out which things here are relevant for the diagnosis that we're going to talk about today, which is the decompensated cirrhosis. Okay, so you can pause that if you want to look at that further, but we're going to progress on. So the first couple of pages in the book are sort of what I call the behind the scenes, where I talk about the pathology, pathophysiology really, about what's happening in this state. And there's a little caveat there that many ICUs would defer a lot of this management to a specialty team like a GI service or a hepatology service if you are lucky enough to have access to that kind of a team. In a lot of places, though, it will be you. So this is why I kind of created this, but really what you need to focus on is what causes cirrhosis, what phase they're in, which is going to tell you how bad it is, The newly diagnosed patient is going to be very different than end-stage, aka fulminant cirrhosis. It's also going to vary based on the complications that they exhibit. So I'm going to list out a laundry list of sequelae that can happen in liver failure, but the reality is most people don't have all of those, and it's all a little bit different for everybody. But you need to know what they are so that you can address them and treat them. You also want to know about the staging and the severity, prognosis, whether or not they're being seen by a transplant service, and if they're on a transplant list. Okay, before we move on, we're going to talk about the 3 forms of liver failure. There is acute, which is a healthy liver that assumes some acute and immediate damage to it. The most common things you will see are going to be a Tylenol overdose or acute ischemic hepatitis, where there's a secondary insult to the liver, like low blood pressure or cardiac arrest. That's a different state than the person who has like chronic liver damage, who's in this state of dealing with a long-term disease that will never go away, but is managing it at home, sort of like heart failure, right? But just like heart failure, something happens along the way to tip this patient over the scales, and then it becomes decompensated. And that's when they show up in your ICU. Usually what's going to cause this is going to be like progression of the disease, continued alcohol use, medication noncompliance, or a secondary insult. So somebody who's got cirrhosis and has that low blood pressure or goes into cardiac arrest, something like that. Sepsis is very, very common, and we'll get to why that's common in a little bit, but cirrhotic who becomes septic is sick. Okay, now we're just going to skip past this section because, again, I'm not talking about acute liver failure today. What I do talk about in this book are the sequelae or the fallout of problems that happen in a state of decompensated liver cirrhosis, and it's going to be a laundry list of problems, guys. You can do one of 2 ways when you're writing your note. You can put them all in this section and do it like in very big detail, or you can put them all in this section and just add minimal detail and create its own problem separately, which I'll get to it in a minute to show you what I'm talking about. All right, decompensated cirrhosis. First and foremost, your assessment, so this part of your note is where you're going to include the information that helped you to form this diagnosis, why you think this person is here for this problem. And it starts with specifying the type of cirrhosis that you have. There's a ton of etiologies. The most common ones are alcoholic, NASH, and viral or autoimmune hepatitis. The etiology, you want to discuss what it was that tipped them over the scale, which I kind of already talked about just a minute ago. And the pertinence, so the pertinent information in your workup that told you this is what your problem is. Alcoholic cirrhosis, you need to calculate a Maddrey's discriminant function score, which tells you whether or not this patient may respond to steroids or not. So do that. You also are going to want to include any contraindications to steroids like bleeding or infection in this section. You're going to want to calculate a MELD sodium score. That's your model for end-stage liver disease. It spits out a number at you. It's going to give you a 90-day mortality. It's constantly changing, just like a blood pressure. It's always a little different, but it gives you an assessment of, at that moment in time, how bad is the liver. It ranges from 15 to 40. Well, it really ranges from 0 to 40. 15 is the lowest number they will consider before putting you on a transplant list. The closer to 40, the worse it is, the worse the prognosis is. I've actually seen it over 40. I didn't know it could go over 40, but I have seen it over 40. But when you get in that upper, like mid to upper 30s range, it's bad. You also want to include here if this patient is a transplant or surgical candidate, including a child's Pew score, which gives you their intraoperative mortality. Have they been previously evaluated for transplant? Are they ruled out as a candidate? Your LFTs are important here. Yes. LFTs will rise when the liver is damaged. But what I need to tell you guys is that if the liver is completely dead and there's no more parenchyma left to damage, it may be normal or just barely elevated. So I don't want that to be a red herring for you. I also talked a little bit about the pattern of the LFTs, which is, I think, super interesting. I did include this article, which I will include a link at the bottom of this video too. I highly recommend you go and look at. I found it very helpful in breaking down how to evaluate the pattern of how things look on your fish bones there. How the pattern of, is the AST greater than an ALT by a large amount, which can indicate alcohol? Is there a cholestatic pattern where the T-bili and the alk phos are elevated more than the others, which indicates that there's gallbladder or ductal problems? So anyways, go check that out if you have time. And then we're going to go through the sequelae of what happens because of the damaged liver. So you're going to want to list each one that your patient is experiencing and the pertinent diagnostics and exam findings that support your diagnosis. Now we're going to start with portal hypertension because portal hypertension is essentially what causes almost all of the rest of the problems. The rest of the problems you're going to see are in large part related to this deranged physiology. And this is when a cirrhotic fibrous liver kind of squishes down, becomes contracted, and squeezes on the portal vein. The portal vein transports 80% of the body's blood flow back to the heart. So when that sucker is got a stricture in it and nothing is flowing through it, you have a backlog of problems. All kinds of issues related to blood pressure in the veins upstream of the liver. And that's what's going to cause these other things, starting with bleeding varices. And they can be in the stomach or in the esophagus. We tend to more commonly see them in the esophagus. So varices are collateral veins. These are just like varicose veins. Think about a big, engorged, tortuous varicose vein just inside the esophagus. They become engorged and they often rupture, leading to GI bleeds. So you want to assess whether or not this patient has been on prophylactic treatment for this. If they have known EV, they are most likely going to be on a beta blocker if the blood pressure will tolerate. So you want to know if they're on it and have they been taking it. You also want to note if they've had any previous EGDs, which discuss the severity or where they're at, and whether or not there is a consideration for TIPS. Okay, hepatic encephalopathy, also a very common thing that you will see with decompensated cirrhosis, and this is a rise in the ammonia level. Now, the last little bullet point there, the ammonia level does matter, but hepatic encephalopathy, the diagnosis, is not dependent on the ammonia level. You can have HE without an elevated ammonia level, and you can have an elevated ammonia level without an HE. It's clear as mud, right? But it's a clinical picture in combination with that number. So you want to assess whether or not they have asterixis. That's when they put their hands out, they're going to flap a little. That's pretty sensitive. You're going to want to assess how bad the lethargy and confusion is. Is it coma level? And use West Haven criteria for grading how severe it is. Interestingly, diurnal sleep pattern may be an early sign of hepatic encephalopathy, and this is when people have their nights and days flipped. Most all of these people have some degree of ascites, so you're going to want to discuss your exam findings. Do they have a fluid wave? Do they have pitting edema? They are both a little bit different, indicate different things, but do an assessment and see what you're seeing at the bedside. You also want to discuss your radiographic findings, talk about how bad it is. On the imaging, are they talking about fat stranding? How tense is the abdomen? How uncomfortable are they? Do you need to do a paracentesis diagnostic, meaning you're just tapping them to get a sample to find out if it's infected? Or therapeutic, where you're taking volume off to give them some relief and or to prevent compartment syndrome, or both. You might be doing both. You want to assess whether or not they're getting large volume paracentesis on a regular basis, because many of these folks are. And are they on prophylactic SVP coverage, and do they need it now? Jaundice. So jaundice related to the elevated bilirubin level. So talking about that cholestatic pattern on your LFTs, is the alk phos and T-bili greater than the AST and the ALT? Do they have scleral icterus? Are they itching? Cholestyramine can help with that. You also want to check the bile ducts for patency, because you can have a bile duct like a stone or something going on with the ducts themselves that are causing this problem and or worsening the liver failure. Portal vein thrombosis. Okay, this is interesting. So this can mimic or worsen portal hypertension. Cirrhosis sets them up for this because there is stricture to this vein, and so there's low and slow flow of blood. So anytime blood is stagnant, you are at risk for forming clots. Now, there is something called Budd-Chiari syndrome, which is its own problem that can directly damage the veins, that causes narrowing and strictures to the hepatic veins and kind of mimics PVT. You are going to diagnose this with a right upper quadrant ultrasound with Doppler flows to evaluate the portal vein. And you can rule out a thrombus if the report reads that hepatopedal flow is noted or is okay. Thrombosed vein would read hepatofugal flow or non-forward portal flow. If there is a thrombus, you have to discuss treatment with all the specialists, your attendings, the people that are helping you, the GI team, and the families, because there's risk benefit to this, because these are people who are already set up for risk of bleeding, and now I'm going to add an anticoagulant on top of that. It's a big, big risk. So you want to talk this through. Which segues into thrombocytopenia. Yes, these people have low platelets. Why? They have low platelets because they don't produce as much, because the liver is failing to do what it needs to do. The spleen is sequestering platelets, and there's increased destruction, and all of this leads to low platelet numbers. So this just sets them up for bleeding. And this is one of these problems, and the next set of problems I'm going to talk about, the next 2 or 3, really are things that you could create its own problem for. The reason I specifically put it under this section is so that everybody who's involved in this care of this patient is aware that, yes, the platelets are low and it is directly related to the failing liver. It also paints sort of a better picture of, the whole body system being damaged because of this liver. Moving on to hypoglycemia. So this is the inability to maintain blood glucose levels, and this is typically a late stage of liver failure. Hyponatremia. Okay, the hyponatremia exists because of the portal hypertension and the systemic vasodilation. So fluid is retained, the RAS system is activated, and then this causes the body to hang on to more fluid, and then it dilutes out the sodium. So the sodium is retained as well, it's just retained in less proportion to water. So they have a hyponatremia. This is also the same physiology that leads to the development of ascites. It increases morbidity and mortality, which is why it's part of the MELD sodium equation. Coagulopathy, so many factors originate from the liver, including vitamin K. So I like to get TEGs. I'm a big fan of TEGs. I think they can be very helpful in directing your factor repletion, particularly in someone who's bleeding or you need to do a procedure on. Hepatorenal syndrome, so the kidneys may fail because of AKI or shock or hypovolemia. But if you've ruled out those causes, then you probably have HRS. It's a very specific problem. It's a very poor prognostic indicator, and we'll talk to some of the management later. Hepatopulmonary syndrome, which is fascinating to me, y'all. So everything's vasodilated, including the pulmonary vasculature. So even in the capillary beds, they're very engorged and dilated. So blood is just like rushing through there. It's very, very viscous. So you've got fast blood running through, which is not slowing down in order to get gas exchange. So blood will return to the left side of the heart without ever really getting fully oxygenated. This is sort of like the opposite of pulmonary hypertension. How do you diagnose this? Get an echocardiogram with a delayed bubble study. And I put it in all caps because often enough when I order this, I don't get the delayed one. I get the immediate one because most people are ordering an echo with a bubble looking for an intracardiac shunt. They're looking for a PFO. So this is where the tech or someone will inject agitated saline that's got air agitated into it, so they're bubbles. So the bubbles will travel to the right side of the heart. And if there's a PFO, we'll go straight to the left side of the heart. What's different in a delayed study is that the liver cirrhosis patient with hepatopulmonary syndrome, these bubbles will go through the right heart, not immediately past the left heart. They'll go through the right heart, they'll go into the lungs. The bubbles will never get lodged there because they never really wedge down into these small little vasculature beds, and then they return to the left side of the heart. So you'll get bubbles in the left side of the heart like 3 or 4 cardiac cycles after it was injected. Symptoms you're going to see orthodeoxia. This is when you sit the patient upright and they desat. When you lay them down, they improve, which is the exact opposite of way things are supposed to be. You also get platypnea, which is where shortness of breath resolves when they're laying flat. So weird. So if they have hepatopulmonary syndrome and you're seeing these symptoms, I put this stuff like in plain format, easy to read, right here under this note. So if they have hepatopulmonary syndrome, I'm going to include these 2 things here. Lastly, distributive shock. Now, these people are profoundly sensitive to any type of distributive shock, aka sepsis, which is the common one. And this is why. I will never forget a guru walking me around the ICU, and he said, "Brianna, do you know what the primary problem is with cirrhosis?" And I thought, I don't know. He said, massive vasodilation. And he's right. So the portal hypertension is preventing blood flow. So everything gets backed up. Those blood vessels get engorged. They get leaky. Everything third spaces out. So they're chronically walking around hypovolemic because it's all in the third space. They're walking around chronically with a low SVR. What is this like? This is just like a patient who is septic. So you put sepsis on top of a patient who already has sort of the physiology of sepsis, and you augment it. So they are very quick and very prone to decompensating because of sepsis. Any kind of infection, they're going to be set up for this. So a lot of times their blood pressure is low, they're on midodrine. When they come in to see you, you are going to be very aggressive in starting vasopressors early on, and you are going to use the utmost of caution in removing volume for these people. And we'll talk about that when we get to the ascites section a little bit later. Okay, let's move on to our plan. The second, or in this case, third page, following the assessment, I talk about the plan of what you're going to do for each of those problems. So you're going to consult your GI or hepatology team and find out if this patient has been evaluated for transplant or can be evaluated for transplant. You want to make sure you're identifying the cause. Check a hepatitis panel if you need to. Alcoholic cirrhosis, we talked about, may respond to steroids. That Matarese discriminant function score is critical. So you're going to want to talk to your GI team. If they're probably going to be already doing these kind of things, but in case they aren't, I want you to understand the whys, right? Steroids are one of those risk-benefit discussions because there are often contraindications to this in our patients, the bleeding and infection being the primary ones. So again, risk-benefit on whether or not this patient is going to get the benefit out of the steroids. You're going to want to trend your LFTs. You're going to want to avoid things that worsen the liver. You're going to want to avoid benzodiazepines. And I want to stop and talk about this for just a second, okay? Benzodiazepines accumulate in these people because there is a slower rate of absorption, there's a longer half-life, and there's slower drug clearance. So there are a handful, there are three benzos which do not have this pharmacodynamic effect, and that would be the lots. So lorazepam, aka Ativan, oxazepam, which is Serax, and what is the T? Temazepam, which is Restoril. The last two are not going to be super duper effective, particularly in somebody who is withdrawing from alcohol. So Ativan is sort of what you're left with. But there has been as of the date of this recording, there has been a massive shortage of Ativan, so it's hard to come by. Do not give them Versed or really any other kind of benzo because it has, you have no idea what the actual effect is going to be. In this book, I included a study, and I will put the link in the video below as well, that indicates that patients who are placed on benzos who have not been on them chronically face a five-fold increase of hepatic encephalopathy during days 3 to 10 of benzo use. So what does that mean? That means the patient who's in alcohol withdrawal, like our sample patient who's in alcohol withdrawal, who's got a poor liver, who's on the floor getting a CWA with Versed or Librium. So these benzos accumulate and you have unpredictable time frame in which this medication is going to be processed. These patients are the ones that will just stop breathing on you. So you should avoid benzos as much as you possibly can. You also want to talk about prognosis. Is it poor or guarded? Is there an immediate or reversible problem like infections or SBP? Segueing into a palliative care discussion, you need to have them or you need to consult palliative care on these folks. And then the other plan, I'm going to talk about specific to each of the problems that we talked about above. Number one being bleeding, NG tube, MPO, PPI, or PRBCs, vitamin K. You want to talk about what the bleeding source is if you know already. And treatment is going to be specific to the etiology. If you have massive EV, you're going to want to consider a Blakemore, Minnesota tube. You're going to want to give them blood back. You're going to plan for an emergent EGD. If they're stable, you would consider a beta blocker. And this is also an indication for TIPS. So let me talk about TIPS here for just a second. This stands for transjugular intrahepatic portosystemic shunt. And yes, I had to read that because I can never remember. This is essentially where they're going to go in through the IJ. They're going to feed a catheter down in there. They're going to go down into the hepatic vein. They're going to create a tunnel that routes around that squished down portal vein. They tunnel something out and then they basically deploy a stent that reroutes blood flow. So think about this kind of like a cabbage for the heart, except it's for the liver. Fascinating stuff. There's just a lot of indications in which you can't do a TIPS. It will make things worse. And those are when the pulmonary hypertension is severe, if they have TR, if they have heart failure, active sepsis, HE, or septic shock. But TIPS is talked about a lot when you have people with EV that keep bleeding. Ascites. So paracentesis, have you done it? Are you planning to do it? Is it going to be diagnostic, therapeutic, or both? You probably want to put them on broad spectrum antibiotics if they have ascites there and you're concerned about infection. You want to cover SBP. Typically, they're going to grow some type of gram-negative causing this. Plus or minus vanc are often used. You're going to want to give them some albumin, in particular if you're doing a large volume paracentesis, or say you do a para, you take fluid off, and then a couple hours later they start dropping their blood pressure. Give them some albumin back. And this would also be an indication for TIPS. Jaundice. So with jaundice, this is the bilirubin rising. That's what's causing this. So you want to make sure you are ruling out any other causes than the liver failing. So looking at the gallbladder, the ductal issues, start with the right upper quadrant ultrasound. Cholesterol can help with the itching. HE, you're going to want to give them lactulose cefaxamine. You're going to want to trend the levels. If it's severe, dialysis can help, but it's very slow. Portal hypertension, there's really not a lot to do for this, but you are going to want to make sure you rule out a PVT. So make sure you get that right upper quadrant ultrasound with the Doppler flows. And do they need a TIPS evaluation? Thrombocytopenia, transfuse is needed. My threshold is around 10 to 20, or if they are actively bleeding, or if we have a procedure where we need to kind of bulk them up a little bit so we reduce the risk of bleeding. Coagulopathy, reverse is indicated if they're on something. Vitamin K. Hyponatremia, so fluid restrict if they're stable enough to do that kind of thing. Correct hypokalemia, consider hypertonics. I've never given someone hypertonics because typically this is a chronic and slow developing hyponatremia, so people adapt to that. Hypoglycemia, again, late stage. Feed them if you're able. Start a dextrose infusion. HRS, which is probably going to be under your AKI plan as well. I mean, I would definitely, if you have kidney injury, I'm going to have it as its own problem. But if you think HRS is the cause of that, you might put that here. So HRS specific treatment includes albumin, terlipressin, if you have that available to you, dialysis. Now, here's my caveat about dialysis and liver failure. If you don't have an immediately identifiable problem that you can fix, do not offer dialysis to this patient until you talk with your nephrology team, because it is very controversial. If there's no bridge to transplantation or there's nothing to fix underlying, it's almost always going to be contraindicated, and a lot of places won't even offer it as an option. So don't offer it to your patient and get their hopes up and then not be able to provide it to them. Hepatopulmonary syndrome, so O2 supplementation. There's really not a lot to do for this other than bringing awareness to it. Maybe a good little note that says that they will improve if you lay them flat, that kind of thing. Shock. So antibiotics, rule out SBP via para, treat the shock normally to keep your MAP greater than 60. You don't need that super robust greater than 65, although if the kidneys have taken a hit, you probably will. But they live kind of with low MAP, so you don't need to target the higher ones. You can give some albumin, crystalloids, and careful evaluation of volume status and volume responsiveness. Okay, so now we're going to move on to the sample that reflects what I would have written for the patient that we talked about earlier. So it looks like this. The top part is the assessment, and then underneath it is the plan. This is what I recommend in the book, and this is kind of what I would use as a sample that I would copy and paste in my EMR, and I would just change the specific details. So this is secondary to alcoholic cirrhosis. You always want your first line to say why it is, why they have cirrhosis and why it is decompensated. So we've said that here. It's alcoholic cirrhosis in the setting of ETOH use with a GI bleed and intolerance to his rifaximin and lactulose, which he hasn't been taking. That's why we are where we are. Your Maddrey's discriminant function score is high. You're going to appreciate GI Rex because you're not going to make this decision by yourself. You're going to talk about the hyponatremia. The sodium is low. Again, changes morbidity, mortality, and your MELD, which is next. You're going to talk about your child's Pew score, which tells you your intraoperative mortality risk. So for patients, particularly that are being considered for transplant, you want to know this because you may call a transplant center and have them evaluate him, and they're going to ask you this. And if he's too sick to even undergo surgery, they're not going to take him. So it's important to include that. Your INR talks about your coagulopathy and your thrombocytopenia. I also make a little note here that this particular patient was on dual antiplatelet therapy, and that is going to complicate the platelets being low. We talk about when the last drink was, which tells me a little bit about him going into alcohol withdrawal and what to expect. I mentioned that he is followed by a GI team and he is not a candidate because of his alcohol use. I give you the LFTs there. We talk about the ammonia level and that there is delirium. So this line right here is giving you an indication of how bad his hepatic encephalopathy is, and that this is probably related to not having any lactulose plus or minus disease progression, but that's another topic. And then the West Haven grade 2 HE classification. But I also put this little caveat here. Classification complicated by contributing conditions, and that is because sepsis and alcohol in and of itself will cause confusion. So what does that really mean in regards to how severe the HE is? I don't really know. It's just bringing awareness to it, really. I also mentioned that there is jaundice and icterus present. Hematemesis, that he has bleeding, so we're making a note discussing that there is some GI bleeding, which is a complication. The ascites is there, and we see it on CT, and there is an element of hypoglycemia. Less than 80 is not so great, and this is a late sign of liver failure, so no bueno. I end it by bringing awareness to the fact that there is shock and multi-system organ failure with this, which is going to talk about how poor the prognosis is. Under the plan, we have a GI team helping us, which is very appreciated. We're going to talk to them about the steroids. We're going to trend the sodiums, keep the potassium up, keep them in PO. That's talking about the sodium. Low threshold for platelet transfusion, although I'm not giving him any right now. Vitamin K to reverse the coagulopathy, checking a TEG, pending EGD, we'll need airway support. And here I mentioned that I'm going to talk about the GI bleeding problem elsewhere. But I put it here because it is again, a complication of the cirrhosis. So that's why it's there. We're going to trend the LFTs and the ammonia level. To treat the ammonia, we're going to have to talk to GI about when we can give lactulose. We could consider rectal if he's not having any rectal bleeding right now. However, this gets real tricky, so it needs to be a discussion. We're going to add Xifaxan once he's taken PO. We're going to trend the sugars, start dextrose infusion, diagnostic paracentesis pending. Right now, this patient had low blood pressure, so we are not going to be able to do it yet. But there is a concern for sepsis, so we need to know. For now, he's on antibiotics, and we're treating any SBP. We're treating shock, and our goal map is greater than 60. Our right upper quadrant is pending, and I talk about why TIPS is not probably going to be an option for him. And then I end it with that this is a poor prognosis. Y'all, when the families are reading these notes, it's sort of nice to tie things up with a bow. Be very, very clear with those who are reading it that there's a lot going on here, and this is not so good. Okay, so that's all I've got for you. Hopefully this is very helpful to you, and you can start building your dot phrase for liver failure to make your life easier. If you want more information like this, please do go check out my website and see if the book is something that will be helpful to you in your practice. Good luck, and thanks for watching, friends.